Hi everyone, for our experiment we decided to use discrete trial training to increase expressive emotion identification in individuals with dementia. So, why should we study this? It is reported that 1 in 10 elderly persons has a diagnosis of dementia. Dementia is a continuous deterioration of an individual's cognitive abilities due to damage such as stroke or disease such as Alzheimer's. Symptoms include impaired memory, difficulties in language and communication, and mood changes. As an alternative to traditional medical treatments, behavioral research looks to environmental factors that may influence symptoms of dementia. Individuals with dementia and Alzheimer's often experience problem behaviors such as aggression, disruptive vocalizations, and communication and discrimination skills. These problems can also be seen in populations commonly studied in behavior analysis, such as individuals with developmental disabilities and autism. Through a behavior analytic lens, it allows us to focus on contingencies that aid with individualized care of dementia patients and decrease problem behaviors in this population. There is limited research in behavior analysis and behavioral gerontology that address the issues of facial emotion recognition in elderly persons with dementia. An early study conducted by Malatesta addressed emotion communication skills in young, middle-aged, and older women. Researchers aim to develop a behavioral means of assessing emotional expressivity through an emotion induction procedure. Participants were asked to recollect, re-experience, and describe 3 types of emotional experiences: sadness, anxiety, and anger, and their facial expressions were videotaped in each session. Results indicated that the induction procedure was effective in evoking emotional responses. Hargrave sought to investigate facial emotion matching, facial emotion labeling, and same different emotion differentiation in patients who were diagnosed with Alzheimer's disease, healthy elderly, and non-demented psychiatric patients. Results indicated that Alzheimer's disease patients were significantly impaired on all 3 measures. It was also indicated that Alzheimer's disease patients had a selective impairment in labeling facial expressions of sadness. Carroll conducted an investigation that used discrete trial training, a method that individualizes and simplifies instructional procedures that promote skill acquisition, to compare efficacy of error correction procedures. This technique is commonly used with children on the autism spectrum disorder. Results indicated that for all participants, multiple error correction procedures were effective. So our research question is, if discrete trial training is an effective teaching method shown to improve communication, academic, social, and self-help skills in children with autism spectrum disorder, can this same method be used to increase emotion detection in the elderly with dementia? There has been little to no research in using discrete trial training as a method of skill acquisition amongst those with dementia and of Alzheimer's type. The purpose of our study is to evaluate the effectiveness of discrete trial training with facial emotion labeling for individuals with dementia.
Participants were 3 elderly adults who had been diagnosed with dementia of the Alzheimer's type. All 3 were female and under the care of staff at a memory care assisted living facility. Betty was a 77-year-old female previously diagnosed with dementia. She scored a 13 on the MMSE, which indicated she was moderately impaired. Minnie was an 85-year-old female previously diagnosed with dementia, and she scored a 3 on the MMSE, which indicated she was severely impaired. Lastly, Doris was a 70-year-old female newly diagnosed with dementia of the Alzheimer's type. She scored a 17 on the MMSE, which indicated that she was moderately impaired. All sessions took place in a standard-sized testing room at the Memory Care Assisted Living Facility. Sessions took place at the same time on Monday and Friday for 7 weeks straight for a total of 10 intervention sessions and 3 baseline sessions. The materials consisted of a table and 2 chairs, data collection sheets, colored facial photographs depicting the 6 basic emotions, the MMS exam, and a video camera to record sessions for more accurate procedural reliability and IOA. A multiple baseline across participants was used to evaluate the effectiveness of DTT on expressive emotion identification. Measurement of accurate responses were conducted using accuracy on a DTT datasheet. Experimenter recorded whether the response was correct, C, or incorrect, I, for every trial conducted. As you can see, mean IOA for baseline was 80%, and mean IOA for intervention sessions was 90%. IOA for probe sessions / maintenance sessions was 100%. MMSE sessions were conducted by the memory care assisted living facility's geriatric psychiatrist. This person was different from the individual who implemented the intervention sessions. The purpose of this pre-assessment was to assess the participant's cognitive impairment. Baseline simply consisted of conducting sessions of 10 discrete trials for each emotion in the absence of any correction or positive reinforcement for correct responses. Baseline phase was terminated after a participant visually showed stable responding. Intervention sessions consisted of 10 discrete trial sessions and 10 trials in each session. Every session, regardless of performance, was implemented identically for each participant. For facial emotion labeling, the participants were shown a colored facial photograph of one of the 6 possible emotions: anger, sadness, happiness, fear, surprise, and disgust. They were then asked to verbally label the emotion. Experimenter held up the photograph and said, "What is this emotion?" Participants had to correctly respond within 10 seconds, or the response was prompted once and then marked incorrect. A reinforcement and stimulus preference assessment was previously conducted. The preference assessment identified the reinforcers to be used. Betty was to receive drinking sugar-free peach tea for 3 seconds. Minnie was to receive praise statements such as "Good job, Minnie," or "You identified that emotion really well, Minnie." Lastly, Doris was to receive tokens to work towards hearing a story from the experimenter. 5 tokens, 5 consecutive correct responses, were needed to hear a 3-minute story. Listed here is Betty, Minnie, and Doris's mean percentage of overall accurate emotion identification. On the next slide, you will see the graph of their accurate identification. In general, happiness increased the most for all participants, while sadness stayed consistently low. This was consistent with previous studies that we found. This graph shows average accuracy of each participant for each session. During Betty's intervention phase, there was an increase in trend and performance was stable. Her mean accuracy during intervention sessions was 36.67%. The range was 31.67% to 41.67% accuracy. In Minnie's intervention phase, there was a change in level and an increasing trend. Her mean accuracy during intervention sessions was 21.33%. The range was 10% to 35% accuracy. Lastly, during Doris's intervention phase, there was an increasing trend and performance was stable. Her mean accuracy during intervention sessions was 51.83%. The range was 41.67% to 56.67% accuracy. This figure shows average accuracy for each of the 6 emotions. In general, accurate identification of happiness increased the most for all participants, while sadness stayed consistently low in accuracy. Sadness was only 0 to 10%.
And now on to the discussion. As stated earlier, our independent variable was that the application of discrete trial training with emotion labeling for 3 female participants with Alzheimer's and dementia. Discrete trial training proved to be a highly effective tool in labeling emotions. All 3 participants improved in their ability to recognize emotions. According to the results, the easiest emotion to label was happiness, and the most difficult emotion to label was sadness. Now, do the results coincide with the introduction? 2 different studies supported our results in which Alzheimer's and dementia patients have difficulty when labeling sadness. Solomon and Ruffman, 2004, found that anger and sadness were difficult to recognize. However, our results contradicted this by showing that anger was the second highest recognizable emotion. Mara, 2008, found that the ability to decipher emotions through facial recognition decreases for the general geriatric population. This could be why the percentages only increased by an average 10 to 15% from baseline to intervention. Internal validity was accounted for by conducting sessions at the same time, 5:30 p.m., and at the same location for each session. Internal validity was not accounted for in the order that the photographs were presented during the intervention phase. The photographs were presented in the same order for 10 consecutive trials within one session. Depending on the cognitive ability of the participant at the time, they could have memorized, even for a brief period, the order of these emotions. Construct validity could be another threat to internal validity because one of the participants, Doris, developed a connection with one of the individuals providing her positive reinforcement. This could be an explanation as far as why Doris produced the highest improvement. Multiple treatment interference could have threatened internal validity because depending on the medications provided for the participants, their overall performance could have been affected. There were a few limitations to this study. One is that this was only conducted on women, and another would be that this was only conducted in one setting. This could lead to a lack of generality across settings. We have a few ideas for future research. We could expand discrete trial training to other genders, for example, men only, or comparing men and women and their ability to recognize certain emotions while using discrete trial training. Another idea could be to use the intervention used within the current study and apply it to various individuals with memory, language, communication, social functioning, and mood limitations. Even expanding the comorbidity of the study by pairing Alzheimer's and dementia with another disability. One route could be to separate the emotions into categories. For example, study negative emotions versus positive emotions.